Hey everyone, and welcome back. Today, we are diving deep into a topic that affects up to a quarter of reproductive age women, abnormal uterine bleeding, or AUB. Now, it can be really easy to just brush this off as a bad period, right? But for a clinician, it's actually a critical signal. It can point to a whole host of underlying health issues. So we're going to break down how to decode that signal. Let's get right into it.
To make this super practical, we're going to anchor our entire conversation around a real-world clinical case. This isn't just some textbook problem. This is a situation you'll see all the time in gynecology. Understanding the systematic approach to solving this is absolutely crucial. So let's walk through it together, step by step.
So here's our roadmap for today. We're going to start with our patient's story, and then I'll introduce you to this brilliant classification system that clinicians use to organize all their thoughts. From there, we'll follow the diagnostic trail, check out the treatment options, and then we'll do a special focus on two of the most common causes, PCOS and endometriosis, before we wrap it all up with the bigger picture.
All right, first things first. When a patient, just like the one in our case, comes in talking about heavy bleeding, it's so important to remember that this is a symptom. It's a signal. It is not the final diagnosis. Our job as clinicians is to figure out what the body is trying to tell us.
So what officially counts as AUB? Well, it's an incredibly broad term. The American College of Obstetricians and Gynecologists defines it as pretty much any bleeding that deviates from what's normal for that person, whether that's in volume, how long it lasts, how often it comes, or how regular it is. This could be anything from a little spotting between periods to these prolonged, heavy flows that can actually lead to anemia and really impact a person's quality of life.
And that brings us to the central challenge, right? The list of things that could cause AUB is massive. It ranges from structural problems inside the uterus to systemic hormonal issues. So when you're faced with such a broad differential diagnosis, where do you even begin your investigation? Well, the answer is right here. This is the Palm-Cohen classification system, and it is a brilliant mnemonic that organizes all those potential causes. The easiest way to think about it is this. The Palm side covers structural issues. Think of it as the hardware of the uterus. So we've got P for polyps, which are growths, A for adenomyosis, where tissue grows into the uterine muscle, L for leiomyomas, which you probably know as fibroids, and then M for malignancy. Then, the Cohen side covers all the non-structural causes. This is the software or the systemic issues. That includes C for coagulopathy or bleeding disorders, O for ovulatory dysfunction, which we'll talk more about, E for endometrial issues right at the cellular level, I for iatrogenic, which means it's caused by a medical treatment, and N for not yet classified.
So, now let's see how this framework is actually put into action. A clinician uses this list not just as a random bunch of possibilities, but as a systematic checklist to guide their investigation from the moment the patient walks in the door.
The whole investigation follows a really logical flow. You always start with a detailed history, just listening to the patient's story. Then you move to a physical and pelvic exam to check for anything obvious. After that, lab tests can help you investigate that COEIN side of the framework, right? Checking for hormonal imbalances or bleeding disorders. And finally, imaging. Usually a transvaginal ultrasound gives you a crystal clear picture of the uterine hardware, helping you spot any of those palm issues like fibroids or polyps.
And this right here brilliantly illustrates the power of that very first step, the medical history. Just by asking about the pattern of the bleeding, a clinician gets a massive clue. Think about it. If the periods are coming like clockwork, but they're just extremely heavy, your suspicion immediately leans toward a structural Palm cause, like a fibroid. But if the timing is all over the place, irregular, unpredictable, that points you strongly toward a non-structural Cohen cause, and most often, that's going to be ovulatory dysfunction.
Okay, so once the investigation starts to narrow down the cause, or sometimes causes, from that Palm-Cohen list, the treatment plan can be tailored specifically to the problem. This is exactly why that systematic approach is so important. It dictates the entire course of action.
Broadly speaking, treatments fall into two big camps. Medical options are usually the first line of defense. This can be non-hormonal like NSAIDs that reduce prostaglandins, or tranexamic acid, which helps stabilize blood clots and can cut menstrual blood loss by up to 50%. It can also be hormonal, using things like contraceptives or a progestin-releasing IUD to regulate the cycle. On the other hand, you have surgical options, which are really there to definitively treat those structural palm problems. For instance, a hysteroscopy to just go in and remove a polyp or a fibroid, or in more severe cases, a hysterectomy.
Now, I really want to take a closer look at two conditions that are incredibly common drivers of AUB and can be pretty complex to diagnose: polycystic ovary syndrome, a classic cause of ovulatory dysfunction, and endometriosis.
Okay, so polycystic ovary syndrome, or PCOS. It's the most common endocrine disorder in reproductive-aged women. The diagnosis is standardized using what are called the Rotterdam criteria. A patient has to have at least two of these three things. First, oligo or annulation. That just means infrequent or totally absent ovulation, which is the direct cause of the irregular bleeding. Second is hyperandrogenism, so high levels of androgens, which can show up as things like hirsutism or acne, or you can see it in their blood work. And third, the presence of polycystic ovaries on an ultrasound.
Next up, endometriosis. And this number, it's staggering. The World Health Organization estimates that endometriosis affects about 1 in 10 women and girls of reproductive age across the globe. That's around 190 million people. So it's a condition that every single clinician is going to encounter.
So, the crucial point here is that endometriosis is a chronic, systemic inflammatory disease. You've got tissue that's similar to the lining of the uterus growing outside of it. This rogue tissue can cause inflammation, scarring, and just debilitating pain. It can also lead to heavy bleeding. And this is critical. There is currently no cure. All the treatments we have, whether they're medical or surgical, are aimed at managing those symptoms and improving quality of life.
So, after going through the clinical framework, the diagnostic pathway, and some of these specific diseases, let's just zoom out for a second and think about the bigger picture. Why does all of this matter so much?
It matters because the menstrual cycle is so much more than just a reproductive function. The medical community is increasingly viewing it as a fifth vital sign, right up there with your body temperature, pulse, breathing rate, and blood pressure. A regular, predictable cycle is a sign of overall health. An irregular one, like AUB, can be the very first clue to a whole range of other issues, from thyroid problems to metabolic syndrome.
And that really brings us to our final thought. If the menstrual cycle is in fact a vital sign, a window into your overall health, then it's worth paying close attention to. It's not about being panicked by every little change, but it is about being informed and being empowered to advocate for your own health. So the question we want to leave you with is this: what is your cycle telling you?